Good afternoon, and thank you for joining us today. My name is Lee Montville, and I'm the Director of Special Sales at Springer Publishing. Today we are presenting Nurses on the Front Line, Combating Workplace Violence with Alexander Minar, Assistant Professor of the Adult Gerontology Acute Care Nurse Practitioner track at the Tang Ching Fen Graduate School of Nursing at the University of Massachusetts Chan Medical School, an acute nurse practitioner at UMass Memorial Medical Center in Worcester, Mass. Before we begin, a quick reminder. This webinar is being recorded and will be available on demand at www.springerpub.com/videos in 5 to 7 business days post live event. If you have any questions today for the presenter, please type them into the Q&A box on your Zoom control panel, and I'll bring them up at the end of the presentation. And if you forget to ask a question, there'll be a brief survey sent at the end of this webinar, and you can include your question there. Now, let's get started. I'll turn the presentation over to Alex.
Perfect. Thank you very much, Lee. I'm excited to have this opportunity from Springer to be able to present on this topic of workplace violence, which I think is very important. So to start, I really would like to sort of understand who the folks are that are here. So if you wouldn't mind taking this poll, just telling me where you work. We'll pause for a moment as folks are able to answer that. Perfect. So we've got people everywhere except urgent care. So excellent. I think, this is going to be impactful. Workplace violence happens everywhere, or can happen everywhere, particularly in healthcare. So we'll touch on areas or of interest for everybody that's attending this webinar today. So the goal for today's webinar is really to identify the prevalence and types of workplace violence that we as nurses face. We're going to discuss some of the practical techniques for de-escalation and personal safety during a potential violent encounter, and then talk about the role that institutional policies and leadership play in protecting staff, and really how we as nurses can advocate sort of up the chain of command to ensure that we have a safe working environment. So to start, you kind of have to understand what a definition of workplace violence is, and there's lots of different definitions. The top two on your screen you can see are from OSHA, which is the Occupational Safety and Health Administration, right? That's a government agency. And then the second one is NIOSH, or the National Institute of Occupational Safety and Health. And it's important to sort of know how those two interact. So OSHA sets and enforces workplace standards, while NIOSH focuses on the research, education, and recommendations. So I'm going to reference both of those as we go through this presentation. So OSHA is sort of the enforcer, and NIOSH sort of makes the recommendations and comes up with a lot of the evidence. And then the two other definitions that you'll see on your screen are from the World Health Organization and the International Council of Nursing, and then the American Nurses Association. And I'm going to read that one because I'm not going to read all four, but the ANA says that workplace violence is any act or threat of physical violence, intimidation, or other threatening, disruptive behavior that occurs at the worksite. So you'll note that all four of these are very similar, and they're all pretty broad as far as defining what workplace violence is. When we get further down in the presentation, we're going to actually look at what NIOSH classifies workplace violence into 4 categories and give examples of each of those. So we will get a little bit more specific as we move through the presentation. So to start, we need some statistics as to why this is an issue. The statistics on this page and the next page actually come from the Bureau of Justice Statistics, as well as the Bureau of Labor Statistics, and from NIOSH, the National Institute of Occupational Safety and Health. So The first one's shocking to me. So this is a large time frame, 1992 to 2019. And this is sort of the worst outcome of workplace violence, right? Homicide, so death. And there were almost 18,000 workers were victims of workplace violence that resulted in homicide. Now that is, right, that's a number of years, 1992 to 2019, but almost 18,000 homicides as a result of workplace violence is astounding to me, and why we're still having conversations about it today. Now, the next bullet point, is a huge improvement, right? We're talking about 454 homicides took place in 2019, and when you compare that to the height of workplace violence-related homicides in 1994, it was almost a 58% decrease. But I think we would all agree, right? One homicide related to workplace violence is too many, but a 58% decrease does show that some of the work that government agencies have been doing and institutions have been implementing is working, but clearly it's not enough at this point. If in 2019 we still had over 400 homicides related to workplace violence. And then there's a lot more workplace violence that is non-fatal, right? So when we look at a smaller time frame of 2015 to 2019, we can see that the average annual rate was about 8 violent crimes per 1,000 workers, looking at workers that are over the age of 16. And on an average, 1.3 million non-fatal violent crimes in the workplace occurred. So, there's still a lot of workplace violence around us. Now, when we think about those non-fatal injuries that we were referencing in that 2015 to 2019 timeframe, over 500,000 of those injuries required evaluation and treatment in an emergency department. So over a 5-year period, over 500,000 people had to be seen in the ED related to workplace violence. And then when we think about, non-fatal injuries due to workplace violence resulting in days away from work, we can see that it impacts female workers greater than male workers. And when we think about loss of days of work, a quarter of the patients that need to be out of work for workplace violence are out of work for anywhere from 3 to 5 days. And another 25% of those actually take more than 31 days to recover before being able to return to work. So when we think about it as just a loss of viable workforce, workplace violence actually impacts that significantly. So we've got some of the statistics and have an understanding that workplace violence clearly is a problem. Yes, we have made some improvements, but there's still some pretty astounding statistics that go along with workplace violence. So the next thing we wanted to do is sort of better define workplace violence and give some specific examples. This is important because, when we think about reporting it and classifying it and then focusing interventions to prevent and or address workplace violence, we really want to be able to classify or narrow down the specifics of what type of workplace violence we're dealing with. So there are 4 main categories: criminal intent, patient, client, visitor, worker on worker, and then personal. And we're going to go over each one with an example. So when you look at any literature about workplace violence, you're going to see that there are these 4 categories that are referenced. And they will either be referenced as criminal intent or type 1, or together, type 1 criminal intent. So this is really a type of violence where the perpetrator has no legitimate relationship with the business or employee, and they're just committing a crime in the workplace for the person, that is the victim. So an example of this would be like a home health nurse who is going to patients, going to their next client or patient, and en route to seeing that patient, they're mugged or robbed, right? So they were at work doing their job, considered in the workplace, and just sort of a person that has no relationship to them or to the job comes in and assaults them to steal money. Okay, when we think about this in the healthcare worker sense, or even in the narrower frame of just nursing, this is much less frequent as far as the types of workplace violence that we see as nurses, but it does occur. Next, we have the patient, client, or visitor workplace violence, or type 2 workplace violence. This is the most common that we see in healthcare. And I'm sure we've all had an experience or had a colleague, a very close colleague, that's had experienced this type of workplace violence, type 2, patient, client, or visitor. One or two examples that come to mind for me are in a local emergency department at a community hospital nearby me. There was actually an emergency room nurse who was stabbed by a patient in her care. I have a personal example, which is not nearly as severe as that, of working in the intensive care unit and a family member sort of entering the intensive care unit, without being properly admitted into the ICU, because they wanted to see their patient who had just had their family member who had just had surgery, and the patient was not ready to be seen yet, and actually pushed me out of the way to be able to get into the patient's room. And again, that's a much less severe example, but that would be considered type 2 or patient, client, and visitor workplace violence. Type 3 or worker on worker workplace violence is more considered sort of lateral or horizontal violence. It could be considered bullying. It doesn't necessarily have to be physical. It could be verbal or emotional abuse that's unfair, offensive, vindictive, potentially humiliating. It's oftentimes associated with hierarchy, with either seniority and or institutional hierarchy as far as management levels go. This is probably the most frequent that we see in healthcare or as nurses, particularly when we're thinking, a close second when we think about type 2. This would be the next type of workplace violence that we see sort of in the field of healthcare and in nursing. And finally, type 4 or personal violence is really more closely aligned with something that might be in conjunction with domestic violence. So it's individuals who have an interpersonal relationship with the intended target, but no relationship to the business or workplace. So an example here is, we have, it looks like a bride and a husband in the top right here. So if the bride was a nurse at the hospital and the husband came into the hospital, has no relation to the hospital, doesn't work at the hospital, isn't a patient, client, or visitor, and came in and started to threaten his, wife and or nurse in that hospital, that would be an example of type 4 or personal workplace violence. So it's important to sort of differentiate the types of workplace violence that we see, again, because it's going to inform our prevention strategies and or how we address that workplace violence when it does occur. So workplace violence isn't simple, right? If it was simple, we would have addressed the issue. And based off of the statistics, we know that it's not, it's not a closed issue. So there, as we're talking and think about what factors influence workplace violence in your particular institution. Some that I put up here that are influencing factors for workplace violence include staff shortages, lack of prevention efforts, or lack of protective regulations, whether that be at the state, federal, or even the institutional level. Simply exposure to violent individuals, increased patient morbidities, where we know that is ongoing, right? Patients are coming in sicker, have more comorbid conditions. That increases stress, which can increase the likelihood or potential for workplace violence. Some other factors that aren't necessarily in a blue bubble on the screen include, mental health in general, or in mental health training, lack of training in general of how to de-escalate patients, families, visitors, coworkers. Workplace dynamics play a huge role in workplace violence. Organizational culture, right, is going to definitely influence workplace violence. We talked about staff shortages, but just workload in general can influence, right? Increased stress, all can influence workplace violence. So the purpose of this slide really is to say it's multifactorial, and to help us focus that when we think about prevention and or interventions to address workplace violence, we need to take evidence to come up with the best interventions and strategies for prevention. But then we also need to think about the institutional specific characteristics that need to be addressed when we're working on strategies to prevent and intervene with workplace violence. So back to our poll, we had a person in the emergency department, someone in the ICU, a couple people in primary care, and I think one on the wards, but nobody in urgent care. So when we think about that, the literature actually tells us, because we can look at what the reports are of workplace violence, that the majority or the most frequent areas that have reports of workplace violence include the emergency department, which may not be surprising to many of you. Also, waiting rooms. Now, those could be waiting rooms anywhere, right? The emergency department, in the hospital, these can be stressful areas where patients' families are either waiting for care or waiting to hear about care. So again, high stress areas that can increase the probability of workplace violence. And it's documented that this is one of the more common places where workplace violence occurs. So psychiatric EDs, as well as psychiatric ward units, are places where there is a higher propensity of workplace violence to be reported. And the last one, which was more surprising to me, but long-term care facilities is actually the on that list of 4 where workplace violence does occur at a higher frequency based off of data that we can find in the literature. So we've established that there's a problem. We've defined workplace violence and then gone down through the 4 different subcategories. And we have an understanding of where workplace violence occurs. But what are we supposed to do about it, right? So what can I do? What can you do as nurses that work in this environment where we know workplace violence is somewhat prevalent? Well, we can focus on personal safety. We want to be able to know the signs of escalation in our patients, families, coworkers, and have the ability to hopefully de-escalate that before violence occurs. We should leverage some assessment tools. If you don't have those embedded in your institution, we're going to go over 4 or 5 that are validated tools that are fairly simple to use and can identify risk of violence. And then we're going to talk about reporting for a little bit, because if we don't report it, it has a lot less impact on, adds a lot less weight to interventions as well as investment in preventing workplace violence. So if you don't report it, it's like it didn't happen. And if we don't know it's happening, it's really hard to fix or address the issue. So, starting with absolute basics, personal safety, right? They're dressing for success is one of the best things that we can do. So we can see here, there's 2 healthcare workers sort of scanning what looks like maybe some labs in a healthcare facility. When you think about dressing for success, right, it's really back down to basics, right? Is your hair, do you have long hair? Is it tied up and out of the way? Could it be easily grabbed by a potential perpetrator, right? Is your clothing loose or too tight, right? You want to be able to be agile. So if it's too tight, is it restricting your movement? If it's too loose, is it something that a perpetrator could grab onto if violence were to ensue? We can see the person in this picture in the white, you can see has a lanyard around their neck. Is there a quick release component to that lanyard? Or could a perpetrator grab that lanyard and have total control over that person's head and neck? Right? Or even thinking about the gentleman wearing eyeglasses, right? Is there a tie around those, around the back of his head? Could those be grabbed? Right? There's a lot of things that go into thinking about preparing yourself to be most successful if violence were to occur. It could come down to as simple as your footwear, right? Thinking about being able to move or be agile if violence were to, erupt or occur in your particular area. So some very basic things that we can do is just think about what we're wearing and think about if I were a perpetrator and I was trying to get a hold of this person that I'm working with or this nurse, what could I grab? What could I do? And then not wearing those, or making sure you have the quick release lanyard, or your badge has a quick release if it's attached to your to your chest. Or if you've got a cell phone attached to your belt buckle, is that able to come off quickly, or is that something that a patient could grab and potentially hit you with? Simple things that could make a big impact if workplace violence were to occur in front of you. So another thing, and again, these are pretty simple interventions that we all can apply to our everyday work, is know your environment. Where are your exits? Where are you standing? You never want your patient or your families to be between you and your exit, right? So thinking about, right, where are you positioned in the room in relation to your patient, to your family members, and to being able to exit the room? And if you're going to be in what might be a more vulnerable position, maybe you need to have another colleague in the room with you. One, so that, if something happened, they were able to call for help, or they were able to help get you out of the room. The other thing that we can see, right, because of reporting, is that there are times that there are higher likelihood of workplace violence to occur during our shift. And the literature tells us that meal times, shift changes, and while transporting patients are times where there is increased disruptive behaviors. So again, keeping that in mind, knowing your surroundings, knowing what time of day it is, can sort of inform the likelihood or potential occurrence of workplace violence. So into some more specific cues, right? There are verbal cues and nonverbal cues that can be displayed or heard in a perpetrator that has a potential perpetrator that has escalating behaviors. And some of those verbal cues, of course, raised voices, verbal threats, threatening tone, or aggressive language. And then some of the nonverbal cues are pacing, restlessness, erratic movements, a fixed stare, or if the patient or the visitor or the potential person that you're concerned about is withdrawn or refusing to engage. Those are all behaviors or signs of potential escalation in behavior, and those can be early signs that can then prompt us to intervene. So being very aware of those. And when we look at our violence risk assessment tools, which are coming up on the next page, they actually, implement evaluation of some of these topics. So we're going to go through 5 tools now pretty quickly, but these are tools that are validated and that are looking at risk for aggression and or violence. Some are predicting it out 24 hours. Some are looking at institution level sort of risk assessment. And, these are things that can be easily implemented within your practice if you don't already have them at your institutions. So the first one is the DASA, or the Dynamic Appraisal of Situational Aggression, right? So it's a tool used to assess the risk of imminent aggression in individuals. This is particularly looked at in the setting of mental health care, and it helps identify patients who may be at risk for violent or aggressive behavior in the next 24 hours, right? So it's looking forward, and it classifies individuals into low, moderate, and high classification. And it really focuses on 7 dynamic risk factors, which can be assessed on the individual behavior in the past 24 hours, right? So you're looking backwards to predict the risk of potential violence or aggressive behaviors in the future. And they're looking at factors like negative attitudes, impulsivity, irritability, verbal threats, sensitivity, perceived provocation, and anger when requests are denied, and unwillingness to follow directions, right? So some of those actually fall into some of those verbal and nonverbal cues, but this is actually a validated tool that can sort of risk stratify people into low, moderate, or high risk for aggressive behavior or violent behavior in the next 24 hours. The next option is the STAMP framework, which is pretty simple and useful, in my opinion, right? So STAMP stands for staring, tone, of a volume of voice, anxiety, mumbling, and pacing, right? And if the patient is exhibiting some of these, there is a likelihood that this is going to result in some aggressive behaviors and or violent behaviors. And if you see these, it's a time where you can intervene early and implement some strategies to de-escalate a patient. This is particularly useful in the emergency department, right? Because just like we said stamp, we read the factors that we're looking for, can be done very quickly to assess a patient and then make a determination of, hey, this person is definitely at risk for an escalating behavior and or a violent behavior. So what can we do to intervene on this before that happens? So it's really about identifying risk early. So the next one we have is the BVC risk assessment, or the Brosette violence checklist. So again, this one is looking for risk for violence again in the next 24 hours. This risk assessment is focusing on 6 specific behaviors: confusion, irritability, boisterousness, verbal threats, physical threats, and attacking objects. Each behavior gets a point, and then those points are totaled up. If you have 0 points, you're low risk. If you have 1 to 2 points, you're moderate risk, and 3 or more is high risk. So again, it's predicting or looking at potential risk for violence in the next 24 hours based off of sort of observable traits within a person, and then allows you to sort of risk stratify for the next 24 hours. And if they're higher risk or moderate risk, there are strategies or a plan that can be put into place to prevent or de-escalate those patients from ever getting to the point where violence, could be an endpoint. Next is the ABC of violence risk assessment. Again, this is a quick practical framework for evaluating potential violence, especially in triage in the emergency department. And it emphasized a systematic approach through 3 key components of assessment, behaviors, and conversation. And again, it's really designed at identifying individuals at risk and then facilitating an appropriate intervention, right? So identifying early that there is a heightened risk to then implement strategies to prevent escalation to violent behaviors. And then the last one is the Emergency Department Workplace Violence Questionnaire. This is a little bit more of a hefty assessment, right? It's a 21-item questionnaire, but it's really good because it's meant to objectively assess the occupational risk of workplace violence in the EDs, in the ED, as well as identify organizational and environmental factors contributing to this risk. And it's meant to guide interventions to reduce and or prevent workplace violence, right? So it's, again, forward thinking and on a more organizational and environmental level evaluation to, again, prevent violence from occurring, assess risk, and prevent workplace violence from occurring. So, 5 really great tools. 2 are focused, well, 3 are focused on the ED, and 2 are focused more in the mental health risk assessment framework. But again, these are pretty quick and easy tools that can give you more of an objective indication that there is a heightened risk of violence, and then you can implement strategies to then de-escalate and or prevent violence from occurring. So, I mean, that's great, but like, what are those things that you can do? Well, de-escalation is something that you need to practice to be able to be good at. There are some, again, just like we evaluate verbal and nonverbal cues to make an assessment on whether someone is at higher risk for potential escalation of behaviors or violence, we need to think about that in ourselves. So body position and posture can make a big impact from our standpoint when we're trying to deal with someone that is having escalating behaviors, right? It might not be the best idea to walk up to somebody straight in front of their face with your arms crossed, being like, what are you doing? And telling them to calm down, right? That's not going to work. But a better approach might be to be calm, or at least act as calm as you can, sort of acknowledge the patient and what they're saying. You don't have to smile, but you can have a noting what they're saying. Of course, you want to respect their personal space. Never, touching a shoulder is probably the wrong thing to do. You want to stay outside of arm's length or leg's length. and you don't want to approach head on. You want to approach more from the side or at an angle. And when you're communicating with this individual, you want to set limits. You want to use a command form to express a desired behavior, and then what the consequence is if that behavior or that request is not followed. Um, so, so right, it requires practice to be tactful in this, and we always have to remember that violence begets violence. So if we get to the point of violence, it can be a snowball effect, and we really want to try to avoid that. So more simply put, right, this is a resource that gives you great examples of verbal communication. Instead of saying, hey, calm down, right? Because I don't know if you have ever had someone tell you that, or if you ever told somebody that, like, it just sort of irritates people. So in a better way, you might want to say, hey, I can see that you're upset. Like, what can I do about that? Or instead of, trying to maybe extract a person from what seems to be escalating situation, and you like point to them and say, you come with me, you can say, hey, may I speak with you? Right? In a professional manner, to try and actually, have a de-escalating approach to your interaction with this person. Same thing with body language, right? Standing rigidly and directly in front of the patient is not the best idea. Coming at the side, staying at arm's length or leg length. Faking a smile is not going to go well, right? We all know when someone's faking laughing or faking smiling, it's better just to have a neutral face, maybe to nod like you're understanding. But really, right, these are quick, easy examples that you can implement with yourself that can, in and of themselves, de-escalate a situation. So finally, or moving forward a little bit more, your safety is paramount. So you can't care for patients if you're not safe yourself, and you want to have the safety of others in mind. So ideally, what happens, or what needs to happen, is that there should be an assessment tool or some form of assessment that is identifying risk and or identifying patients that have escalating behaviors, and there needs to be an action plan set in place. If this happens, this will happen, right? So if there's an escalating patient, security is going to be called, or there's going to be a multidisciplinary response team, which some institutions have, which include a nurse, a prescribing provider, a mental health specialist, and security. If this happens, if the patient starts to get violent, there will be restraints placed, whether those be physical or chemical. And this really needs to be ingrained in the institution and in a policy so that folks know how to respond when these instances occur. If we're not able to de-escalate, this is what will happen. And those functions need to be in place. So, the best protection is prevention. So the National Institute of Occupational Safety and Health, or NIOSH, actually says there are 10 things that employers should do to prevent violence. Now, the majority of these are easily applicable to healthcare and to the world of nursing. And as you read through these, we're not going to read through all 10 of them, but think about, are these done at do they apply to your institution, and are they being done at your institution? Because the people that do the research and make the recommendations, right, NIOSH, are saying these are the things that we should be doing. And if you're not, these are things that you should bring to your institution, your place of employment, and say, hey, do we have a silent alarm system and or a panic button, right? Do we have good visibility with use of mirrors or raised platforms? Are our hallways well lit? There are some pretty simple things. Do we have video surveillance equipment to monitor activity? Do we have locked doors for staff-only areas? And do we have control over who comes and goes at our facility? Right? There are really some basic protection or prevention practices which can be implemented to prevent workplace violence from ever occurring. So, right, then the question is, do you feel safe at your workplace, right? This is a hypothetical question, but going back to the statistics, right, we know that 2 nurses per hour are assaulted in the acute care setting, right? And this is in the United States. There was some literature that supported, or that documented, that 1 in 4 psychiatric mental health nurses, right, 25%, had a disabling injury from an assault. Now down to some numbers here highlighted in red. 20 to 60% of incidences, so incidences of workplace violence, are actually reported. So that means at worst, 80% of events are not being reported. At best, 40% are not being reported. Like, that's too much information to not have to inform interventions. So really, reporting is a huge component that we're going to talk about in a couple more slides. And then thinking about, again, we talked about days lost of work for recovering from workplace violence. When we think about all of the work days that are lost, 13% of missed work days can be attributed to workplace violence. So we can sit here and cover our eyes and say, I don't see this, it's not a problem. Or, right, we can all be shocked and be like, this is a problem. We should do something about this. And us as nurses have the ability to advocate for some of these changes to occur, because we do have a body of evidence that suggests best practices about how we can prevent workplace violence. So now back to reporting. So how do we report workplace violence, and, or how do you report it? Again, it's a hypothetical question, but if you're sitting there saying, I have no idea, well, then, your charge the next time you go into work is to find that policy, find that reporting system, and figure out how you do it. And if you're sitting there, you're like, yeah, I know how to do it, but it's like this, right? It's a maze. I have to click all these different buttons. I file a report, and I'm supposed to do all this on my shift while I'm here, the nurse, balancing, 3 different things, standing on one leg. I have to give meds to one patient. I have to document my vitals. And Sally down in room 4 needs to get put on the commode. And yeah, I was, punched in the face by my patient at 9 o'clock this morning, and it's 1 o'clock now, and I still have all these things to do. When am I supposed to report workplace violence? And that's where you need to advocate that this be a priority at your institution, so that when these instances occur, reporting should happen. It needs to happen. And from one step beyond that, once reporting happens, what is done with that? How does the institution, or how does management tell you what will change, what will be done with that? Because it is one component of this is, yeah, we need the data to be reported so we know what's going on. But then 2, right, we need to know what is the action, what has changed, so that we know, right, there's actually going to be an improvement, and there's going to be some benefit to actually reporting workplace violence. And again, we talked about 4 subcategories of workplace violence. Workplace violence doesn't have to be someone getting punched or someone getting kicked or physically harmed, right? There is sort of this emotional, bullying, belittling, sort of vindictive component that is considered workplace violence and also should be reported because it's not right. So that's some things, right, that we can do as nurses, but what can and what should our employers do for us? So, is workplace violence going to be 100% prevented? Probably not. But we do know that every employer is responsible to adhere to OSHA's general duty clause that states that all employers, regardless of size, must provide a place of employment free of recognized hazards that are causing or likely to cause death or serious harm, right? So again, just like the definition of workplace violence, that's pretty vague. But when we think about those terms in the concept of workplace violence, we can think about what employers should do. And these are really recommendations about what employers should do, right? The employer should have a written, right? It's key, written zero tolerance policy, right? We do not accept or condone or allow workplace violence, right? We have a zero tolerance policy. We do not allow it. And we have a written down prevention program, right? Because if you talk about it in meetings or you talk about it in your institution, that's great. But then how do you refer back to that? It needs to be written down. When it's written down, it's committed to. Resources are committed to it. So if you don't have that, you should advocate for your employer to have a written down zero tolerance policy as well as a prevention program in place. There should be workplace violence training emphasizing what to look for, what to report, and what to do during an actual incident. And so we covered some of that today in this webinar, but this should be annual training, if not more frequently. Encourage reporting, right? These things need to be reported. If it's not reported, it's almost like it never happens. But it needs to be easy, right? We talked about that. It's not always easy. And, probably needs to be some level of confidentiality associated with it. And, our employers or institutions can consider outside expertise to provide a threat assessment training as well as physical security upgrades, right? You can't do it all by yourself. Sometimes you need other experts, right? We don't, nurses take care of patients. We do that really well. We're trained to do that. We're not necessarily trained to think about threat assessment training and physical security upgrades. So maybe we should consult with somebody that actually does that. So those are things that you can advocate for your employer. You can also advocate at the federal level, right? And at the state level. We know that OSHA is responsible for creating the standards nationwide. We also know that the Joint Commission, so if your place of work is accredited by the Joint Commission, they have requirements that were implemented in 2022 and 2024 that say specifically places that are accredited by the Joint Commission need to meet these requirements for workplace violence. When you think about advocating at your state level, like policies vary. So you need to know what the policies and what supports you have or what legislation there is about workplace violence in your state, and then be able to reach out to your legislator before some of these violent events occur. Of course, after they occur, you should be reaching out, but even before, what are they doing for you, right? As a person in the state that this person is, is a legislator for. So in summary, we know that workplace violence is prevalent based off of the statistics. Maybe it's a little bit better, but it's still too much. We need to know that we're on the front lines, so that increases our risk for workplace violence. We're like 5 times more likely to experience workplace violence than most other sectors of work, just because of us working in healthcare on the front line, right? It increases our risk. Prevention is everything, right? If we can prevent it, we can, right? We can predict that workplace violence is going to occur. So if it's predictable, it's preventable. So we really need to think about prevention. And we have Benjamin Franklin here, right, saying that an ounce of prevention is worth a pound of cure. So if there's not prevention strategies at your institution, those are things that you need to advocate for. There are evidence-based prevention strategies that can be employed. Know the basics of de-escalation, right? There was a slide that offered some verbal and nonverbal cues that we can implement when we are interacting with a patient that may be escalating. A zero tolerance policy is a must. If you don't have one at your institution, you need to start advocating for one. Incidents have to be reported, and not just reported, they need to be acted on. The reporting process needs to be easy. It really, should have a level of confidentiality. And then advocate for change, because, we can either advocate for change at our institution level, at our state level, and at our federal level. And, nurses are a large number of people. If we advocate together, we can hopefully get some change implemented. So with that, I guess we'll switch over to see if there's any questions.
Sure. Thanks so much, Alex. That was incredible. Such an excellent and informative presentation. We are going to go ahead and take some time for questions now. Just as a reminder, please be sure to type your questions into the question box in your control panel. So the first question we have is from Risa, and Risa asks, hello, Dr. Menard. Do you have any suggestions on how to delicately extricate oneself in a home care environment from an increasingly volatile patient?
That is an excellent question. I think this goes, you got to revert back to, again, so it sounds like you've implemented your evaluation to see that there are signs of escalation. You also need to know your surroundings. So I hope that while you're in that scenario, right? Because every house, like, it must be so challenging going into every house is different. And if it's the first time, you may not know the best setup of the house, but always keeping yourself, your patient, yourself, and your exit, never letting the patient getting between you, and ultimately, if you're at the point where you need to leave, I think that there are, if your safety is paramount. So if you need to leave, you should just leave. How to delicately do it, I think that gets challenging. If there's a behavior that's going on, you can have sort of that forward language and say, listen, I'm not going to be able to care for you because of X, Y, and Z. If we're not able to stop doing whatever that is, I'm going to have to leave, and then setting a boundary and leaving. But otherwise, if it's an unsafe situation, I think that you're better off just excusing yourself and leaving, and you don't necessarily need to give them an excuse if it's that dire of a situation. It's more important that you're safe and that you get out of there. That is a very challenging situation, but that would be my opinion and thoughts on that.
Great. Thanks so much for providing that response. The next question from Susan is, how do you see technology like panic buttons or real-time reporting apps playing a role in future prevention efforts?
So panic buttons, I think, are excellent. If you identify some escalating behavior, you hit the panic button, which then, right, implements that action plan. And that could be that the doors lock, people aren't able to actually get into whatever unit you're in. It also should prompt security to respond, or some sort of response team that can handle the situation that you're dealing with. So I think that is imperative. I think mobile reporting and or ease of reporting is incredible, right? If we can get the reports done quickly, we'll have the information. And then thinking about that, even from like a technology or AI standpoint, if the more data we have, the more data can be analyzed. Is there a way to, leverage artificial intelligence to then look at those reports to come up with better interventions, to identify, different sectors of a hospital or an institution where violence occurs more, to then be able to dedicate resources to those particular areas. And why is technology important in that? Because it can be done faster than something being reported on an online forum and then it needing to be digested by a human and then processed through a committee, and then the throughput is so much slower. I think that if we're able to do it with technology, the throughput is faster, so then you can get the resources that are needed to a particular area faster. Again, going back to hopefully addressing an instance early or preventing it from occurring.
That's great. And actually, there was a question from Mary that was kind of in the similar, that was related to um, to this. She asked specifically, what are some of the most common barriers you see that prevent nurses from reporting workplace violence?
Yeah, I think it's the difficulty of actually doing it, right? I mean, how often, it's hard enough to sit down to be able to have your lunch or to remember to drink your water, to then sit down to be able to document sort of a volatile incident. It takes time, and it can be difficult when you have a full patient load. So I think that is one of the main barriers, is time. I also think ease of access, right? You have to log on to your institution's intranet, and then you have to like put your password in, and then you have to go through, a standardized form. And those are all sort of barriers and make it difficult to report something. So I think it's time, and then it's just the ease of access to the physical, to being able to give the information to somebody or to something to be able to have something done with it.
Great. And the final question from Mindy is the following. Could you elaborate on any success stories or case studies where a hospital significantly reduced workplace violence through either policy and or training?
Yeah, so training has been one of the biggest things, right? So we implemented training at an institution that I worked at. It was actually twice a year, mandatory training. One of them was online and one of them was in person, which focused just on de-escalation techniques. And once the year after that, everybody was trained, we did see a decrease in workplace violence events that were reported. But yeah, the training itself equipped the nurses and the workforce to be able to deal with some of these instances. And it ended up showing that some of it was prevented because the instance of uh, workplace violence episodes had gone down after that training had been implemented and has continued to remain at a lower level as those trainings have been required and are mandatory.
Great. That's excellent. So it looks like we've covered all of our questions. If we can go to the next slide, we wanted to thank everybody for spending time with us today. And thank you again to our host, Alex Menard, for a great presentation. If you're interested in purchasing Alex's book, Fast Facts for Trauma Nursing, you will receive a 25% discount, using the code webinar25 at the checkout on www.springerpub.com. I want to remind everybody that the recorded session will be available on springerpub.com in 5 to 7 business days. Finally, I want to wish everyone a great afternoon, and we look forward to you joining a future Springer Publishing webinar. Thanks again, and have a great day. And thank you again, Alex. Take care.
Thank you.